Good morning. Today we will having a ward round scenario discussion on a patient presenting with acute right upper quadrant abdominal pain. Dr. Rupleka Ghosh is a second year junior resident at I think Ramgir Shapadishan and Bionisha Medical Sciences will present. And with us today will be Professor Shivajyoti Ghosh, who is professor and head of surgery at Calcutta Medical College. So Rupleka, there is a scenario there, and you just read and wait for our discussion.
Okay, sir.
Yeah. Just read the scenario and then start discussing.
Sir, 48-year lady presented to the emergency with pain in the right upper quadrant since evening. BP 140 by 88 millimeter H and pulse rate 112 per minute. How will you proceed?
Okay.
Okay. So please carry on.
So what's your approach? You find a patient in emergency and somebody called you up, and how do you start going through this patient?
Sir, as there is tachycardia and the high
But
BP.
she is not in shock. There is tachycardia, but if you see the BP, she is not in shock. There is no hurry that you have to rush for IV fluid and others. So you have time to proceed with the usual steps in management.
Yes, sir.
Okay.
I will do the pain management at first, and there is no findings even myself according to the abdomen. So I will proceed.
Where is it? Nothing is written. Nothing is written.
Yes, sir.
You
Yes,
cannot
sir.
say there is no finding. You are given a scenario of pain abdomen. There is an emergency call book. Now it is your duty to approach the patient, decide about the diagnosis and then the history examination, then investigation, then your plan management. Pain relief is one, yes, I agree. But what's your steps in management of this patient?
At first, I will take the.
Would you like to go for pain management at the first initial management before examining the patient? Do you think you can miss certain
I
clinical
will take
signs?
the history and examine the patients.
Right.
Then I will do the pain management.
Right.
Okay. Start. Nothing is said. Only pain is mentioned. No other symptom is being managed as mentioned in this. So it is your duty now to go through the detail of history to find out what is the exact situation.
I will take the history about the pain from when it is started and the nature of the pain, and then I will take a history about if there is any associated vomitings, fever.
Pain history is not over. Pain history. There are so many things in pain to clarify. Whether it is the pain of pancreatitis, pain of
the site
cholecystitis,
of
pain
the
of
pain,
peptic ulcer.
any radiations, nature of the pain, when the pain is started, and it is increasing or decreasing in nature. According to the pain source of the site of the pain, radiations, any other site there is a pain or not present, and
Pain starting in one point, getting generalized, are these important? Don't get biased with any diagnosis here. Pain started in the epigastrium, then pain becomes generalized. Does it help in diagnosis?
Yes, sir. If your pain started on one point, then
remaining confined right hypochondriac region or right upper quadrant, is this two scenario different?
Sir, if there is a generalized pain, then diagnosis will be if patient can develop peritonitis, or patient can develop acute pancreatitis, or it can be acute cholecystitis.
Okay, what else? What else?
Sir, regarding the examinations.
No. History. So many things to be inquired in history. You have not talked about jaundice. You have not talked about vomiting, fever.
fever, vomiting, jaundice, any melena, hematemesis.
Go systematically. You see, there is a usual approach for a patient who has got a pain in the abdomen. So many things to be inquired.
Sir, at first I will characterize the pain. Then I will inquire the fever, vomiting, about the patient have jaundice or not. Then I will inquire about the
Now tell us about the important past history. This is a 48 years old lady and pain in the right upper quadrant. So important past history, or rather say negative history. Already
sir, any
history of jaundice.
hematemesis, any melena, any history of anorexia, weight loss.
Okay, history of similar attack in the say last
The
few
past.
months. They're also important, isn't that?
Yes, sir.
History of similar pain in the say past few months, right? Or maybe years before. So these are important, isn't that?
Yes, sir.
Okay. Then what else?
Then I will examine the patients, and at first, after the general examinations, I will do the para-abdominal examinations. If the abdomen is soft, tenderness is on the, I will first inspect the abdomen to see, according to the umbilicus, any organomegaly is seen or scar mark, any venous prominence is seen or not. Then I will proceed for the
In general
palpation.
examination, what are the things you like to exclude or you like to see in general examination?
Sir, on general examination, I will see there is any cervical lymphadenopathy presence or not, or there is
Patient of acute Sireka, Rupleka, don't go hayward. Patient having a right upper quadrant pain, acute onset pain. How a
there
cervical lymphadenopathy matters in this patient?
no, sir.
Tell me a condition where you'll find a acute abdominal pain and then patient has got cervical lymphadenopathy. Mention the relevant points. You're not mentioning about
Sir,
jaundice. You're not mentioning
is
about
there is any
pyrexia.
anemia, jaundice, pyrexia?
So talk of more relevant points when you ask in a ward round scenario is for 5 minutes. Try to understand. He will be examined for 5 minutes in the ward round table. So you should be talking very relevant things.
So you want to exclude jaundice present or not? You want to see the state
Fever
of,
is not.
huh? You want
Yes,
to
sir.
see the nutritional status of the patient, any like signs of this recent loss of weight, if there's, and also you want to see the state of hydration. That is very important, right? And also you want to see
Yes.
the performance status of the patient. These are very relevant at this point, today's scenario. Then what else?
Then I will do the abdominal examination, sir. At first, there will be the inspections. Is there is any organomegaly present or not?
Of
And
inspection, you make out organomegaly. How? How
sorry,
inspection you can make organomegaly?
actually, I am
There are some
sorry,
findings.
sir. Actually,
There are some findings in inspection which may help in diagnosis. Do you find anything in pancreatitis? Any obvious findings? Severe acute pancreatitis?
so Cullen sign, Returner sign.
So look for
There
the
will be
scheme. Look
periumbilical
for scheme. Can it be intestinal obstruction?
changes.
Can it be intestinal
Yes,
obstruction? In that case, what do you
yes,
find
sir.
on inspection?
So the abdomen will be distended,
So
tense.
say that. You cannot
And
say you will find organomegaly on inspecting the abdomen. It's very difficult. Whether liver or spleen, anything is enlarged, you cannot make out on inspection. Then, what else you look for in inspection? Patient has got features of peritonitis. Patient has got features of peritonitis. What will you find on inspection of the abdomen? Any obvious finding? You can suspect that yes, patient is not having some normal movements in the abdomen, which might indicate there is some peritoneal irritation.
Patients will lie superficial. So actually, I have got fever, so I can't.
Oh, you are having fever. You have not read.
Yes, sir, I have read, but I can't.
So these are routine things that you are seeing in an emergency. It is nothing to do with your reading.
Yes, sir. No, sir. I am trying to.
Okay, carry on. Take your time and carry on.
So
Okay,
patients,
if you look at the patient abdominal movements, you understand. Patient who has got a inflammatory condition in the abdominal cavity will have restricted abdominal movements. That is one thing you can observe. Okay, and then you must look for the hernial sites.
Yes, there any venous prominence or hernial sites should be looked for, and the patients in peritonitis should be lie flat, and the abdomen will be distended, and there will be
Any finding in acute cholecystitis, severe acute cholecystitis? Can you have any finding in the abdomen on inspection? Can there be a finding in the right upper corner abdomen in case of severe acute cholecystitis? You have never seen a patient. Where patients come to emergency, you can examine and find there is some finding in right upper corner of the abdomen. What can be the finding on inspection?
On inspection, sir.
I added the term severe acute cholecystitis.
Can gallbladder be seen?
Yes, sir. Can be.
And which condition?
In case of empyema or distended GB, it can be presented as a lump in the right upper
There
quadrant.
can be just a fullness. If there is a lump in the, there is a lump in acute cholecystitis, you can find there is a fullness in the right upper quadrant abdomen. Okay.
Yes, sir.
You see, in what round the approach should be methodical. Now we are going for palpation. What do you look for in palpation in abdominal? In a patient who has got a acute right upper quadrant abdominal pain. I hope you know you will jump to right upper quadrant to palpate.
No, sir. I will start from the left lower quadrant, and then I will after taking proper consent of the patients in a well-lit room, I will start to examine from the left lower quadrant, and then I will see if there is any tenderness presence or not, if the abdomen is soft or not. I will see the distensions of the abdomen, if there is any presentable organomegaly is present or not, or sir, is there is any lump or swelling is palpable or not, any fullness is present or not, is also in this case, sir, is there is any rebound tenderness present or not?
And any role of percussion? Any role of percussion?
Sir, in patient is develop ascites. If a patient is develop ascites or not, I will scan percus. Patient has any obliteration of the liver dullness is present or not. In case of perforation, there will be obliteration of the liver dullness.
Where you like liver dullness obliteration?
So in case in right upper quadrants, and in case of usually in case of hollow viscous perforation, there will be free gas under the diaphragm, so that there will be liver dullness will be obliterated.
In which case? Normally where it is obliterated, and in case of free gas under diaphragm, where the liver dullness will be obliterated.
What do you percuss usually for finding the liver dullness? What is the usual line of your percussion?
So I will percuss 9th, 10th, 11th.
9th is a liver dullness on the right
No,
side. It starts in a fifth intercostal space in the mid-clavicular line.
yes, sir.
So it will be fifth intercostal space on the right side. Now, in case of gas under the diaphragm, right side of the diaphragm, what happens? The gas pushes the liver downwards, right? So fifth intercostal space will be occupied by the gas, isn't that?
Yes.
So if you
Yes.
percuss over there, what will get? So you will get resonant instead of dull note, right? And liver dullness will be much down. So maybe around 6 intercostal space. Okay. So what else?
Rublika, can I ask you a question? You are surgical research confined more to the surgical conditions. Can you mention some medical conditions which can lead to acute right upper quadrant abdominal pain? And that also you need to take in the history and also in the examination. You cannot confine only the surgical conditions. Name some important medical conditions which can cause such acute abdominal emergency. This happens. A lot of patients are getting admitted in.
Yes, sir. It can happen.
Yes.
Like in pneumonia.
Yes. Which pneumonia? Pneumonia where?
Right-sided pneumonia, basal pneumonia.
Basal pneumonia. Yes. Then
Pleural effusion. We have right height failure, acute intermittent porphyria. In case of anemia.
No, tell us about the more common scenario.
Yes. Anemia usually does not present with acute abdominal pain. That you can try to say sickle cell anemia, where patient hemolytic crisis.
Acute myocardial infarction, particularly the inferior wall infarction.
Yes.
Acute myocardial inferior wall infarction. That can also present as the pain in the
epigastrium or right upper quadrant.
Right upper quadrant. Yes.
So your history should also cover these points. Your history should also cover whether the patient has got any previous history of chest pain, whether the patient has got any history of diabetes, whether he has got any exertional dyspnea. Earlier, these are all important things to be asked. Whether he has got cough, chest pain, hemoptysis, they are all important.
Yes.
What are the important surgical conditions you come across in your practice? Important surgical conditions where the patient presents right upper quadrant abdominal pain. Important surgical conditions.
It can be acute cholecystitis, cholangitis, or liver abscess. It can be, sir, acute pancreatitis.
Yes.
Or it can be, sir, peptic ulcer disease, especially in case of, sir, perforated peptic ulcer disease. We decided pyelonephritis, nephrolithiasis, or, sir, it can be, sir, in case of bowel, sir, in case of acute appendicitis, where the hepatic appendicitis.
Yes.
We can face the right upper quadrant.
Intestinal obstruction also, as sir said previously.
Yes, in case of acute intestinal obstruction.
So it should be good. This part you answered well. You should be conversant with the important surgical conditions, non-surgical cause of acute abdominal pain, and based on this, your approach for history will come, because history will help you to exclude these conditions. Okay.
Yes, sir.
So you have examined the patient. Like I give you a scenario: patient has got a tender lump in the right upper corner abdomen, and remaining abdomen there is no finding. It's a soft abdomen, no tenderness up there, but there is a tender lump in the right hypochondriac region. Will you try to elicit Murphy's sign in this patient? You got my question? You palpated a tender lump in the right hypochondriac region. Will you try to elicit Murphy's sign in this patient? Yes or no? No. Yes, you're right. So if the lump is already there, is a tender lump.
I will not.
you will not ask the patient to take a deep breath. Unnecessary patient
Yes.
is having pain.
Pain.
Only when you do not find there is a lump,
Then I
no
will do
tenderness,
the.
in that case, you ask the patient to take a deep breath to elicit Murphy's sign. Okay? Fine. So
Yes,
there
sir.
is a lump there. And what may be the provisional diagnosis from your list of did you put forward? 48 years lady may have previous history of uh, uh, upper abdominal pain and now present to emergency with such acute pain, tachycardia, and a lump palpable there. What is the most reasonable diagnosis?
Sir, acute cholecystitis.
Fine. Acute cholecystitis.
Right. And suppose the patient is having associated fever, high fever with all these features, then
Sir, it can be empyema, GB.
very good. So it could be empyema. Right. So would you like to do parectal examination in this patient?
Yes, sir. I will do.
Yeah. So to complete your abdominal examination,
Abdominal examination, I will do. If
should
there is any associated comorbidities or not comorbidities or associated co-pathologies presence or not, I will do by rectal examination.
okay. Right. So what is now you're going how are you going to manage this patient?
And before that, Ruplekha, now if you go to the Tokyo guidelines, there are some criteria to diagnose acute cholecystitis. Ruplekha got my question. If you go to the Tokyo guidelines, they have defined some criteria to diagnose acute cholecystitis. Can you tell us the criteria? Criteria from history, examination, and some parameter.
So I can't remember. Sir.
Okay. So Tokyo guideline says that patient has presented to you with acute abdominal pain. You find some local signs in the form of tenderness or a tender mass in the hypochondriac region, and patient some systemic signs like fever, CRP rise, and leukocyte count. So these are the criteria to diagnose acute cholecystitis. Have you read about the grading of acute cholecystitis, Tokyo grading?
No, sir, I can't read
You
anything.
have to read that. Now, you see, anybody asking acute cholecystitis will now definitely go to the Tokyo grading for acute cholecystitis. So how is your approach? You now diagnose acute cholecystitis. What are you going to do?
Just one more comment regarding this. In postgraduate level, see, there are very few questions to be asked from the chapter cholecystitis. So there are certain recent advances like this, as sir already says, this Tokyo guideline you should read. Also, you may be asked about the management of acalculous cholecystitis, and also you should know where the prophylactic cholecystectomy is done. So these are the few questions that examiners might be tempted to ask you in postgraduate level. Right. So be prepared for these questions. Sir, yes, sir.
Yes. What's your approach? Now you said trying to manage the acute cholecystitis. What is the investigation and how this investigation will guide you to manage this patient? And what is the steps in management? You see, there are a lot of things now in acute cholecystitis. Not that previous regime of conservative followed by interval cholecystectomy. So many things has changed in management of acute cholecystitis.
Sir, I will confirm my clinical diagnosis first by doing
You can take some question.
ultrasonography.
Okay. Rupleka, you have not read well. Milind is here. I asked Milind to take few of these questions. Okay.
Yes.
Milind, we have just now discussing that we have clinically diagnosed even acute cholecystitis.
Yes, sir.
Now, what's your approach? How do you go?
Uh,
Because you need to confirm the diagnosis and then plan your management.
So we will be doing the first, so as we said, according to the Tokyo guidelines, the baseline investigations we will need to diagnose acute chole would be TLC and CRP. So along with that, this would also help us to classify whether the acute cholecystitis is mild, moderate, severe. Yes, sir. So then as extension to our clinical examination, we would like to do ultrasound of the whole abdomen. Sorry.
And if you go to the Tokyo guidelines, you will find there are some criteria for organ dysfunction.
Yes, sir.
So you have to do some investigations to find out there are some criteria to define organ dysfunction, either by SOFA scoring or by organ dysfunction scoring. So you have to have some investigation so that you can have some investigation parameters in your hand and say that yes, this is a grade 1 acute cholecystitis, this is grade 2 and grade 3. Do you know how they grade this cholecystitis?
Sir, grade 2 acute cholecystitis is based on the TLC count. So TLC count more than 12,000, TLC count more than 15,000.
Okay, better start with grade 1. Grade 1 is, try to understand, grade 1 is mild acute cholecystitis. In that case, patient has presented to you within 72 hours.
Yes,
there is mild inflammation in the gallbladder wall. There is no organ dysfunction.
yes,
that is mild acute cholecystitis. Grade 2 is a intermediate.
Yes.
There is a severe inflammation in the gallbladder wall. That means it is involved the whole of the gallbladder wall. The gallbladder wall thickness is more. There may be some pericholecystic changes. But apart from the severe local inflammation, there is no organ dysfunction. Okay. And the gallbladder wall thickness is defined as more than 4 millimeters. And grade 3 is a severe acute cholecystitis with all these local changes plus some features of organ dysfunction. So that is the criteria. So to define organ dysfunction, you have to have some criteria from other systemic parameters. So that should be a level of investigation. So you have to do a comprehensive assessment of the patient. Okay. Even a urea kit is important. Okay. Yes. Okay. So now you have a situation that this patient has acute cholecystitis, and now based on the investigation, you have classified the patient maybe either to grade 1, grade 2, or grade 3. What is the management? General management first. A patient having acute cholecystitis, you have some general management by the time you continue the investigations.
So, first of all, sir, we will make the patient NPM, and we will, if we feel that the patient is having some form of ileus or distension, then we can also put a nasogastric tube to decompress the stomach. So we will start with the IV fluid resuscitation. I would like to start with crystalloids I would like to start with so 5D or DNS so as to supplement for carbohydrate along with crystalloids such as normal saline. So then further, I would like to go for pain management, sir, in this patient. Pain management, so this patient is febrile and also is having right upper quadrant pain. So I would like to start with paracetamol, sir, which would take care of both these things as an antipyrogesic as well as analgesic, and would supplement it with non-NSAID non-NSAID painkiller, sir, so that it further reduces the pain. So I would also like to start with PPI because the patient would be.
You are putting antibiotics to the end. Why?
So,
here, antibiotic is very important. We should talk of antibiotic much earlier. What antibiotic?
Sir, I would like to give a third generation cephalosporin, sir.
Only?
Along with the anaerobic coverage,
Yes.
such as metronidazole also.
So antibiotic is very important. This is an infective condition.
Yes,
you have to consider giving good antibiotic. You see, fever is just not because of this is because of a ongoing infection. Okay, so these are the components of conservative management. And then now you can grade the patient into 3 grades. How the management will vary.
Sir, in case of grade 1 acute cholecystitis, that is mild acute cholecystitis, if the patient is presenting within the first 72 hours and we have assessed the patient for operative fitness, we can take the patient for operative intervention, early cholecystectomy, preferably by the laparoscopic minimal invasive method. So, if the patient.
And what is the difficulty level? If you consider the difficulty level of grade 1, grade 2, grade 3, what is the difficulty level in doing a lab cholecystomy in grade 1?
So grade 1, sir, we would expect that patient would have adhesions, but these would be loose adhesions. So, sir.
So it's not very difficult to carry out a lab cholecystomy grade 1 cholecystitis. Obviously, you need experienced surgeon for that.
Yes.
Okay, so this is a grade 1 situation where you can go with the early cholecystectomy. What about the grade 2?
Sir, in case of grade 2, so we would have to take a decision whether the patient is stable for operation or not. So because grade 2 would, so it is mild cholecystitis.
Grade 2 is not
sorry,
mild.
moderate cholecystitis.
It's a severe cholecystitis with gross inflammation in the gallbladder wall itself. You see, try to understand. In grade 2, the local inflammatory signs are very severe. Only thing is, this patient does not have a systemic derangement. And most of the patient come within, after 72 hours. Wall thickness is more, count is more.
So we would like to go for conservative management in this patient.
No. Grade, you see, you have to read the recommendation. Grade 2 is not straightforward only conservative. Grade 2 again is resuscitation.
Yes.
You give the patient good coverage of antibiotics, give the patient all other supportive treatment, and these are the patients who may be taken up for cholecystectomy with something in mind. One is it should be in a very good center. Surgeon should be very experienced. And next is you have to follow some decision-making things while doing surgery. That means you may need to do a subtotal cholecystectomy. Okay, so these are the special situations where a grade 2 patient is undergoing cholecystectomy for acute cholecystitis. Okay, so grade 2 you can take up, but you have to fulfill some criteria before taking this patient, because here the patient has got severe local inflammation. It is very difficult to do lab cholecystectomy in this situation. But recommendation is, if you have an experienced surgeon, if you can follow some changes in management intraoperatively, there should be low threshold for conversion. If anything is not visible here, the difficult anatomical situation, you may convert. So low threshold for conversion, changing to subtotal cholecystectomy is another option. Okay. So grade 2, Dr. Ghosh, is it right?
Yeah, of course.
Yeah. So
and you complete, please.
Yeah. What about grade 3?
So grade 3 is where we are having systemic compromises. So we will go for, primarily we'll go for resuscitation and conservative management.
And what else? You need to have some local treatment.
Yes, sir.
Unless you do some local treatment, this patient may not resolve.
In case we can, in case we have that the gallbladder, there is, we see that the gallbladder is distended. In case the patient is jaundice, in case if we are suspecting empyema, so we can go for percutaneous drainage of the gallbladder.
Yes. So in grade 3, usually surgery is not recommended because the other patient has got systemic derangements, and this patient also has a severe local inflammation. So in that case, primarily treatment is conservative. In select situations, you might need to do a tube cholecystectomy, percutaneous ultrasound guided. So if you do a tube cholecystectomy, this inflammation will subside. And what is the next management? If you have a tube cholecystectomy being done, and what should be the next management? Yes.
Internal cholecystectomy.
In that case, there should be waiting period of at least 6 to 8 weeks.
6 to 8 weeks.
One should wait for 6 to 8 weeks to the inflammation to get subsided and go for the management of acute cholecystitis.
Good. So one thing I like to add, that particularly in this part of the country where gallbladder carcinoma is, I would say, not so uncommon, gallbladder carcinoma can also present as acute cholecystitis, particularly this 48 years old lady. Okay, so you'll have to, particularly when the carcinoma is situated at the neck or cystic duct carcinoma particularly. So that part also we should keep in mind, that the probability of gallbladder carcinoma, particularly in case like not resolving quickly with the conservative management.
Ruplika, can I ask you a question? There are often patients admitted in the surgical ward with acute pain abdomen, and you stamp all patients with acute cholecystitis. How do you differentiate a patient who has got acute biliary colic versus acute cholecystitis? Can you give us a scenario? Yes, this is a patient who might be having acute biliary colic. What is the characteristics of a patient who are presenting to you with acute abdomen? But I stamped the patient, then it was a biliary colic, not acute cholecystitis. We have discussed so many things in acute cholecystitis. These all will be not found in acute biliary colic.
So fever.
Before fever, talk of the pain. How long? What is the duration of pain in a patient who has got acute biliary colic versus acute cholecystitis? Duration. This is clearly written in Bailey and Love.
Yes, it's a very old question.
You see, biliary colic pain is very severe. I agree. It's a severe pain, so severe that patient has got impending sense of death. So severe is the pain. But this pain usually gets relieved in hours. Most of the time, 6 hours. It does not go beyond 24 hours. Okay, that is the most important criteria to say biliary colic, number one. Number two, biliary colic patient does not have fever. Biliary colic pain may be associated with mild vomiting, not very marked vomiting. Biliary colic pain, patient having stone in the gallbladder does not usually present with jaundice. If you examine the patient, what will be the finding in patient abdomen in biliary colic? You examine the patient abdomen. Any finding in the abdomen? No. There will be no
sir,
positive.
there will be no specific finding in the abdomen
Yes,
in
specific
case of
क्या
very
कोई non-specific finding भी नहीं है. There is no finding in the abdominal examination in acute biliary colic. If you do the system examination, say general examination, pulse may be normal or patient may have bradycardia. There will be no jaundice. There will be no fever.
Yes.
And if you do investigation, what about TLC?
It will not rest, sir.
Yes,
it will be within
it will
the
normal.
normal limits.
If you do ultrasound, yes, you will not find any inflammatory changes in the gallbladder wall. You may find stones in the gallbladder, but there will be no inflammatory changes. So this is a very common question people keep on asking. How do you differentiate between acute biliary colic and acute cholecystitis? Okay, why patient acute cholecystitis has jaundice? Patient with acute cholecystitis may present with jaundice. The stone has not migrated to the bile duct. Why this patient may have jaundice?
And what will be the usual level of jaundice?
Yes. Patient with acute cholecystitis may have jaundice. What is the explanation for this jaundice? What happens to the gallbladder? Gallbladder is inflamed. Edematous.
Inflamed, wall thickened will.
So, how it causes jaundice?
So there will be biliary.
No, not biliary. It can cause transient obstruction in the bile duct by extrinsic compression. And as Dr. Ghosh has asked, the bilirubin usually does not go beyond 4 mg/cent. It's a mild jaundice. Okay, so it's not that the stone has gone to the bile duct causing this jaundice. Patient with acute cholecystitis may have some change in the gallbladder wall, edematous gallbladder wall, inflammatory mass can compress the CBD temporarily for transient period. Okay, and we have discussed other points in acute cholecystitis. There may be tender lump, there may be tenderness, there may be Murphy sign positive, and other features. Because this needs differentiation. Why this differentiation is important? I often does not discharge all the patients from the ward, saying that no, it was not acute, it was biliary colic. Treatment is different. If it is biliary colic, there is no reason to get the patient discharged from the hospital, come back after 6 weeks. You understand what I'm trying to say? So this differentiation is important, that this patient can be offered cholecystectomy in the index admission. Right. Yeah. So if it is peptic ulcer disease, how the pain character varies? Patient has complementarity, and at the end I come to diagnose this is an acute exacerbation of peptic ulcer disease. So what can lead you to this diagnosis? What should be the important points in history and examination to suggest, yes, it might be a acute exacerbation of peptic ulcer disease? This is not uncommon. This happens. What in history is important to say peptic ulcer disease? What is the classic pain in patient has got a peptic ulcer disease? Maybe I say it's a duodenal ulcer only, not gastric. What will be the classic history in this situation?
Pain will increase after taking the food.
Is it in duodenal ulcer?
No, sir. In general, gastric ulcer, in duodenal
I
ulcer.
told I'm given a scenario. It's a duodenal ulcer. So what is the classic history? Do you know the character of pain in a patient who's got peptic ulcer disease? There is a very classic description of pain. In Belila book, you'll find there is a chart showing chronic duodenal and chronic gastric ulcer, the pain characters.
The pain.
This pain will be try to understand.
Not,
I'm giving you the answer. A patient having a peptic ulcer disease has history of pain of long duration, maybe months or years. And this pain is characterized by periodicity. What do you mean by periodicity of pain in peptic ulcer disease? Periodicity of pain is a definite periodicity in duodenal ulcer disease. In gastric ulcer, this periodicity may not be very marked. Periodicity is patient has got pain for some duration, maybe 2 or 3 months. And then the patient has pain-free period of another 2, 3 or 6 months. And patient has relapsed to the same pain. So this is described as a classic periodicity in peptic ulcer pain. So if you find the patient history that patient has got pain which lasts for about 3 or 4 months, disappears with some conservative treatment, and then come back after 3 or 6 months, this is classic of peptic ulcer pain. Second is, this pain is usually in the epigastria. This pain is usually a burning pain, not a colicky pain of biliary colic. In duodenal ulcer pain, the pain is aggravated in empty stomach. The pain gets relieved in taking meals. So if you find this classic history, you can diagnose peptic ulcer disease. And because
in the old Love, there was I think 5 or 6 points regarding this acid peptic disorder, gastric ulcer and peptic ulcer. Differentiating point: pain, periodicity, vomiting, hematemesis, melena. And how these points differ in gastric ulcer and peptic ulcer. It was very nicely written there. As Sarah already said, the points about the peptic ulcer. The things are just opposite in the gastric ulcer.
So you diagnose the patient has got an acute exacerbation of peptic ulcer disease. How will you confirm the diagnosis now? You have not diagnosed acute ulcer, you diagnosed the acute exacerbation of peptic ulcer disease. How you cleanse the diagnosis? How
so
you? Yes.
Upper GI endoscopy.
First, ultrasound is must. You see,
At
any
first,
pain in this, ultrasound is must.
the
Ultrasound has shown you that gallbladder is normal, pancreas is normal, liver is normal. So ultrasound has given you a lead that there is no hepatobiliary pathology. There is no pancreatic pathology. And you find the classic history that yes, this is a situation like this. When you suspect perforation, patient has got acute exacerbation, and now I'm thinking somebody else KO, it might be perforation. What will lead you to the suspicion of perforative peritonitis following a peptic ulcer perforation? Any change in
the abdominal findings?
Before finding? Before finding? Any symptom will change? Symptom will change with perforative peritonitis if the ulcer leaks. The pain was in the right, upper quadrant. What will happen to the pain if the ulcer starts leaking after admission? Why the
there
pain
will be intractable pain and followed by the sudden relief of the pain when a silent
pain will not get relieved. There will be some diminution in intensity of pain, but the pain will start radiating. From right upper quadrant, the pain will radiate to the right paracolic gutter, right leg fossa, and then become generalized. If you find this classic history, that patient studied the pain in the right upper quadrant abdomen, the pain has gone down to the right paracolic gutter and become generalized. This is a very classic history of a leaking peptic ulcer. So the pain
Yes.
character will change.
Yes, sir.
Okay. So how will you confirm the acute external peptic ulcer disease? It will be upper GI endoscopy.
Yes, sir.
Okay. And then emergency management. Patient came with emergency.
With acute examination of the
Peptic ulcer
peptic
disease.
ulcer disease, sir.
Will you give a NSID in this patient?
No, sir. It will it will cause gastritis, or it will exacerbate the conditions also.
So
So
if
I
you
will
diagnose
not
peptic
go.
ulcer disease, NSID should be avoided. You can give
Yes,
paracetamol or some other
some other.
tramadol. Okay, pethidine congener you can give.
Right. Once the diagnosis is made, then we can give pain management, medicines for pain management. Right. Okay. Then what should we can do for peptic acute exacerbation of peptic ulcer?
I will give, sir, some antibiotics, sir.
Antibiotics for acute exacerbation of peptic ulcer disease. What antibiotic?
So when there is no role for
No, Baba,
prophylactic.
that can come at the end. If I say now it's H. pylori is different scenario. First
Yes.
is the acute exacerbation because of what? The ulcer has increased or there is some irritation of the ulcer by the acid. So how do you ameliorate that in acute situation? The mainstay of treatment is what? Reduce acid. The
Yes,
mainstay of
sir.
treatment is reduction of the acid.
PP.
And in
Yes.
acute exacerbation, there are some preparation in the market which can provide you instant relief. What? What drugs can give you a early relief in acute exacerbation? So many people
Sir,
are coming, MR are coming, they are promoting their product.
H2 blocker, sir.
H2 blocker. You prefer H2 blocker for peptic ulcer disease treatment nowadays?
No, sir, we fill the PPI, proton pump inhibitors.
Yes. So I do answer something which is not the first line of treatment now. And can some liquid antacid provide early relief?
Yes, sir.
How?
So they will form a
Yes. They form a
surface over the stomach bed, and then prevent the gastric mucosa from the
no. We are
acid.
dealing with the ulcer now, you see. We are not dealing with the rest of the gastric mucosa. We are now talking of the
Or
acute, the ulcer which is aggravated. So this liquid antacid, the alginate, can provide a protective barrier for the
yes,
acid
sir.
to act on the ulcer.
Also,
So you can use some liquid antacid containing some alginates. And then you have to give the patient PPI, full dose of PPI.
yes.
And you're talking antibiotics. Why antibiotic may be required?
Then in our country, there will be a common H. pylori infections.
Yes.
So
So
to
if
eradicate
you think of that, this ulcer is because of H. pylori infection. In that case, you consider giving the patient antibiotics. What antibiotics are used for H. pylori treatment?
sir, amoxicillin, clarithromycin, or sir, amoxicillin plus metronidazole can be used. Amoxicillin, sir, and along with that, the full course of the
what is the duration of therapy? What is the duration
sir,
of therapy for H. pylori treatment?
So amoxicillin 1 gram BD for 14 days, and the clarithromycin 500 milligram BD for.
There are some in the market. You'll find there are some combination drugs coming up in the market, marketed
Yes,
as the kit.
H. pylori kit.
Yeah. So that contains some product contains metronidazole, amoxicillin, and clarithromycin. Okay. Apart from
Yes.
this, there are some other drugs also. which are not being favored nowadays, but there are some other products which can also have anti-H. pylori effect. Have you heard of colloidal bismuth?
Yes, sir.
Yeah. So antibiotic will be using when you suspect that
Well, it is
H. pylori
given in
induced
quadrant
lactic acid.
also.
Yeah. So upper quadrant pain abdomen, you must read acute cholecystitis. The idea was to have this one acute cholecystitis, but we have not given the diagnosis acute cholecystitis at the beginning. So just keep your mind open that this can be different diagnosis, and the approach should be based on history, examination, relevant investigations. And we have to, all PG should read grading of acute cholecystitis. This Tokyo grading is very important. Anybody will ask you these simple questions.
Yes, sir. Sir.
Yeah.
Yeah.
Anything else, Dr. Ghosh?
I would like to share something here because
Yes.
nowadays I'm every year I'm asked for as examiner as the preparative examination, FAT examinations of DNB in various.
Yeah.
So there, this word round is nowadays, of course, common in both DNB and MS. So what I find lacking in the students is that ward rounds should be like ward rounds. When you are seeing a patient in the examiner will be there, he will be stand there, and he will be given a scenario, mostly in the form of post-operative patients, or maybe have some complications, and things are written as we have already written here like this. Then you are supposed to examine the patient in front of the examiner, right? So that should start. I think examiner like to see how you are examining the patient. So it should start with greeting the patient. You will have to say, my name is so and so. Then asking for the history, how he's feeling today, any problem of the patient, and then relevant questions you'll have to ask. Then you'll have to go for the first general examination, including all the vitals. Then you'll have to focus on the particular areas. If there's any abdominal operation, so you'll have to see the abdomen, all like inspection, palpation, percussion, auscultation. You'll have to look for the wound. You'll have the other tubes and drains there, how much it is draining, the characters, like if the stoma is there, so all stoma's characters. Then you'll have to decide what is the problem with the patient. So you'll have to check what the previous treatment the patient is getting, and if you want to modify the treatment, that you'll have to answer. So these are the points you'll have to make in a very brief period, say 2-3 minutes, right? So if you practice it, I think you can do it very well, and that is the thing that the examiners like to assess. So regarding this, I just want to share one note, daily notes, right? So these are daily notes, standard daily notes that our postgraduate students are writing. They're advised to write in particularly in the critical ill patients or in the post-operative day 1 and day 2. So that is how they write in my unit. So I just wanted to share it. So this is the patient of bile duct injury was done outside. So this is a day post-operative day, I think is 4 or 9. So this is the patient's particulars. Patient is conscious, alert. I can read it here. So pulse
Febrile, I think.
right.
Yeah.
So all these points are there. You can
Pulse 100,
right.
BP 100 by 110 by 80.
So a small picture has been drawn here, like the lungs. It's like air diminished, air entries like this. These are picture of the abdomen. So these are the wound. These are drains, Riles tube output, drain output, and catheter output. Right. So all these things written. There's the labs reports are written over here. The latest ultrasonography findings and this advice. And also it's good to write this. You can see here the antibiotics. So post-operative day or day 2, this Pipzo and Metrozil day 2. So if you could practice writing notes like this, particularly in the post-operative patient day 1, day 2, day 3, or any critical ill patients, I think you will not be having any problem in facing your ward rounds. So these are a few small things. I think this can help you for your preparations for final DNB or MS examination. So far, ward round is concerned. That's it.
This note Dr. Ghosh has shown I often ask a question like this. Previously, there was a book in the market saying problem-oriented medical records. So whatever is written in this patient is the patient's status, and then you make a subheading of problems. That means this patient has got tachycardia, this patient is having fever, this patient has got drain output of this. So these are the problem with the patient today. And then the advice that is written should be written as plan. So you address the problem with the patient after writing the status, and then you write a plan. How are you going to address those problems? That means for biliary drainage, they plan for MRCP. For fever, they are thinking of doing some more investigations, maybe a repeat of total count, maybe CRP, and then escalate the antibiotics. So this is what the whole note is a pattern of problem-oriented medical record. You take the history and examine the patient, and from that, try to find out the problems on that particular day, and then write how we're going to address those problems. This is a problem-oriented medical record.
Yeah, so you can always improve on these daily notes as sir has suggested. So many things can be improved. Actually, this will give you a very good impression. Right.
Thank you, Dr. Ghosh.
Thanks.
You must read well.
Thank you, sir.
Because these are all simple things.
Yes, sir.
If you are giving
Yes,
one
sir.
topic, you read at least 3-4 books. Now internet is flooded with information. You click internet, you get the Tokyo grading, you get all the updates in management. Okay, so now
Sorry, sir.
it's very easy to face any
able to
such situation. I understand you are sick. Okay.
Sorry, sir.
Okay. Thank you.
Okay, thanks a lot.
Thank
Thank
you.
you.